All right, terrific. Well, I want to thank our three speakers for really three fabulous lectures. And they're all here joining us now, Dr. Pleskow, Dr. Nishioka, and Dr. Nath. So there's quite a few questions, so we're going to just jump right in. Dr. Pleskow, so there are questions related to recommendations for patients who have only an endoscopic appearance of Barrett's but normal biopsies, or biopsy-proven Barrett's without endoscopic appearance, and what do you do for surveillance in those patients? And would you still repeat EGD and put them on PPIs?
So the first the first part of that question is, what do you do with somebody who looks like they have endoscopic Barrett's, but the biopsies come back as showing no evidence of Barrett's? So by definition, that's really not Barrett's. You're probably seeing some fingers of gastric mucosa, gastric cardiac mucosa coming up into the esophagus. So that isn't Barrett's. By definition, you need to see intestinal metaplasia. So if they're having reflux symptoms, I'd certainly treat them with the way you do with anybody with reflux. And as Norm's lecture was alluding to, there are lots of options for that patient population. For the population that you don't see Barrett's, endoscopic evidence of columnar mucosa, cinnamon-colored mucosa, I assume the biopsies showed some Barrett's, but I'm not sure where the biopsies would have been taken from. This may represent intestinal metaplasia of the cardia, and that by definition is also not Barrett's. But again, if they're having symptoms of acid, then likely treat them for acid reflux or their functional dyspepsia. But that's not a Barrett's patient either. So surveillance may be more on symptom rather than on a definition of Barrett's in those two cases.
Okay, terrific. Thank you, Doug. Dr. Nishioka, how do you respond to concerns about chronic PPI therapy for the treatment of GERD?
Yeah, it's a great question. This is something patients ask about incredibly frequently. The truth of the matter, though, is that very few of the purported side effects of long-term PPI use really have not been borne out by rigorous research. So I think that basically doesn't prove that they're not real, but it doesn't prove that they're really there. So I just try to reassure patients. I mean, people are asking about dementia, osteoporosis in particular, neither of which have really been substantiated. So clearly they should be on the lowest possible PPI dose that does the job, but I think reassurance is key.
Okay, great, thank you. Dr. Nath, is it safe to assume a patient with non-cardiac chest pain who has a normal endoscopy, esophageal manometry, and pH test has pain that's unrelated to a GI disorder, or could they be having esophageal spasms that you're just not catching on the testing?
So if somebody has, first, it's very important to establish that it really is non-cardiac chest pain, because we have had patients be referred with normal stress tests and imaging, and it turns out they actually have cardiac chest pain. But I'm assuming that's not the issue. If GERD is always the question, and if they don't have dysphagia, doing an ESMO looking for esophageal spasm would have a very low yield, but it is not inconceivable that they could have GERD with no typical esophageal symptoms, and that's something that you would certainly pick up on a pH test, and that's worth doing.
All right, great. Dr. Pleskow, is increasing dysplasia detection with Watts shown to help to improve esophageal cancer rate or detecting cancer at lower stages at the time of diagnosis?
So what this new tool allows us to do is to assess for dysplasia, and it's been identified. The use of the Watts brush has shown that dysplasia is picked up at a much higher rate than just with Seattle protocol biopsies. And the reason probably is we're looking at more tissue acquisition and then all of the markers that are made as well. So we haven't gotten to that next part of that question yet. Are we detecting earlier cancer? But we are certainly detecting earlier dysplasia than we have been with routine Seattle protocol biopsies and our surveillance techniques. So we will probably see that as additional studies are performed.
Okay, great. Doug, I'll just ask you another one here. So
Sure.
can Barrett's regress in some individuals? And in a patient who has prior non-dysplastic Barrett's, but with subsequent endoscopies that have been negative then for Barrett's, how many negative endoscopies are needed prior to discontinuing screening surveillance?
That's a great question. So I'm not a believer that Barrett's actually regresses, but it's a matter of sampling, and it depends upon the patient and where the biopsies are taken from. And again, I think a lot of people biopsy in a regular Z line, and we're seeing intestinal metaplasia of the cardia, which isn't really Barrett's. And then, so that would explain why somebody was diagnosed with Barrett's and subsequent biopsies are negative. But then again, you know, if they're somebody goes back for another endoscopy, it is sometimes a sampling of where you're taking the biopsies, because Barrett's is kind of patchy. But we also define Barrett's as being greater than 1 centimeter of salmon-colored mucosa with intestinal metaplasia. So I would probably do one more biopsy to assess that, and then say if it's negative, that this is and probably wasn't Barrett's to begin with, and it's probably more intestinal metaplasia of the cardia, which we believe is a separate condition.
Okay, great. Thank you. Dr. Nishioka, what are your second-line treatment suggestions for refractory GERD and hiatal hernia with concomitant Barrett's without dysplasia after PPI treatment?
I'm not sure I fully understand the question. I mean, so the Barrett's and the refractory GERD symptoms are really, in my mind, sort of independent of each other. I think, you know, as Dr. Pleskow mentioned, I think, and certainly someone with long segment Barrett's, chronic PPI use makes sense, symptoms or no symptoms. And so the symptoms should be addressed sort of separately. So the, down the same pathway I sort of described in my lecture. So I would argue just separating those two things, the symptoms and the presence of intestinal metaplasia.
Okay. And then, Norm, is the switch to a different PPI for refractory GERD just simply a psychological intervention? Is it durable?
In many times it is. I don't think we know really whether it is simply psychological or quote real. There is evidence that different PPIs do have different potencies in terms of intragastric acid suppression. So there is some potential rationale, although sort of potency of intragastric acid suppression and symptoms are not necessarily that highly correlated. So it's very difficult to tell, but I'd say if it works, it works. And you get the same thing. People say, "Oh, I can't take the generic brand because it doesn't work as well." It's hard to say.
Okay. All right. Dr. Nath, if the esophageal manometry shows IEM or EJOO, but patient has no dysphagia whatsoever, do you report that study as normal?
So the study has to be reported. The manometric findings have to be reported as they are seen. We always have an addendum for something like EGJ, certainly for EGJ outflow obstruction, that it can be seen first in patients without any symptoms, in which case it probably has no significance. But even if patients have dysphagia, it's very important to confirm the functional significance of EGJ outflow obstruction. So therefore, it requires, to really make the definition, it requires the addition either of a time barium swallow or an endoflip exam. As far as IEM is concerned, you again would simply report it as a manometric finding. In that particular instance, often the dysphagia is not necessarily related to IEM, but even if the patients have no symptoms, many patients with IEM have no symptoms, you simply report the manometric finding.
Okay, great. And so a second question here for you, Dr. Nath. If a patient complains of dysphagia and your EM is normal, do you bother doing provocative tests with?
No, because unless there's some abnormality on the motility study, like it looks, the body of the esophagus looks like achalasia, but the IRP is normal, then you would certainly do a provocative test. But if the patient, otherwise, the yield would be very low. And in most motility labs, I would say the provocative tests are not done if the baseline motility study is normal, unless you feel there's something very unusual about the patient's history, which is rare.
Okay, great. Dr. Pleskow, do you recommend ablation in patients with a high tissue Cipher score or abnormal P53 on biopsies?
Tissue Cipher scores are good predictors for progression to dysplasia, but it doesn't necessarily show dysplasia at that point in time. So I have a long discussion with patients about what these results show. And we've sort of revised some of our recommendations that in the past, people who were anxious and wanted to get ablation, we would do, but there's a fair amount of side effects and, discomfort associated with it. So we tend to follow them much more closely than with a positive tissue Cipher score than with a negative one. So probably go every year, then every 3 to 5 years in those patients. Now, positive P53 is a marker of dysplasia or impending dysplasia, and I would probably go back and rebiopsy them in 6 months rather than going ahead and treat them again, unless there was presence of dysplasia in those samples.
Okay, great. So to Dr. Nishioka, this is a question I think that occurs often. Do you, here we go. How do you manage patients who have long-standing GERD that you attempt to have them wean off of PPI, but then keep redeveloping symptoms?
Yeah, I think that once again, the lowest dose that controls their symptoms is the dose they should be taking. So, and that's not uncommon at all, that there is a dose below which patients really just can't be weaned. And those people are going to end up probably taking PPIs for life. Once again, I think the downside of that is really not significant. So I'm not terribly concerned about that.
Okay. Dr. Nath, someone writes, I thought that the CC version 4 tells us to do swallowing tests in upright position and tells us that in upright, a normal IRP is less than 12, yet you reference of 15. And could you clarify that?
Yes, so in the supine position, the normal IRP would be less than 15. You're correct. In the upright position, it would be less than 12. That's absolutely correct.
Okay, all right, great. Dr. Pleskow, in a situation where there's endoscopic Barrett's but negative biopsy for such, but Watts shows no Barrett's but positive for CDX2, do you still place the patient on PPI and repeat EGD at some point?
Even if they have Barrett's, I will put them on a PPI. And I would go ahead and repeat biopsy probably in 6 months or so, just to get more information and be very aggressive with your Seattle protocol biopsies. I would do 1 centimeter 4-quadrant biopsies for the entire length of the visible salmon-colored mucosa and repeat Watts as well. And there's Watts and there's Watts too. It's like anything else. You have to be really very aggressive and complete. And I use 2 different type of techniques, and I think the video may show that, as I will insert the catheter up and down like this and go around, and then I also will just take the scope with the brush out and just sort of encircle the distal part of the esophagus where we have the Barrett's esophagus. So it makes it somewhat traumatic, but it really gathers quite a bit of tissue and gives you a lot better sampling by doing that technique.
Okay, a quick one, Doug, here is, do you use corticosteroids after Barrett's treatment to prevent strictures in your practice?
I don't. Typically, the incidence of stricture formation is about 3% in RFA and around the same in cryotherapy. So unless patients will get dysphagia with a post-ablation stricture, I don't use steroids, but I do use them in that population. Certainly there's some stuff in the literature suggests using steroids in patients who have had circumferential or near circumferential ESD, where there's a really high rate of stricture formation, close to 50%. So those patients should get some steroid injection.
Okay. Dr. Nishioka, there's a question about any new data on the management of large inlet patches noted in endoscopy for patients with severe reflux.
I'm not aware of any recent data. I mean, I think it's become fairly mainstream practice in patients with appropriate symptoms, typically, sore throat, globus, that kind of thing, where inlet patch ablation actually is fairly effective. It's not 100%, but certainly the majority of patients, I think, if they're carefully selected, will respond well, and it's pretty safe. So yeah, I think I'm not aware of any large studies recently.
Okay. And Dr. Nath, is there any benefit of doing endoflip in patients who have a normal EM and esophageal dysphagia symptoms?
If they have a normal manometry, and I would also say that if they have a normal barium swallow, the yield would be low. However, the endoflip does offer a more sensitive barometer of EGJ function because it's a measure of distensibility. And so there are patients who may have the situation would be a patient who has an abnormal motility in that the esophageal portion is abnormal, but the IRP is normal. That's a situation where an endoflip can be very helpful because that patient could still have achalasia, which would be not picked up by a standard manometry, but would certainly be picked up by the endoflip.
Okay, great. I will just do one last one. We're a little over time, but there are a couple questions for Norm here about, do you have a strategy for how you taper people off PPIs?
There's no sort of, I think, official strategy. So what I typically do is have the dose PPIs and ask them to try that for a week. And if they're doing well, they can have it again. And so that may be a go from 40 BID to 20 BID, 20 BID to 20 QD, being the morning dose, and go with that. I think most people will know within a week whether that's going to work. That's how I do it. I'm sure there are many other ways that work just as well.
Okay. All right. Terrific. Well, I'm sorry we can't get to all the questions, but thank you for those great questions, and thank you to our experts for this terrific Q&A session. We will take a break here now. I think we'll shorten the break so we stay on schedule. If you come back at 10:45, we will continue on with the rest of the morning session. It's 10:45. Okay. All right. We'll see you then.